this streaming?
Yeah, they
Cool.
can see you.
Alright.
Yeah, so what we do is you're here, and then I can go to that on my computer directly. So you can start whenever you are ready.
I can go for it?
You can go for it.
All right. Ready?
Yep,
All right. So is it live or not?
it is live.
Oh, so I'm live right now.
So say hello.
Yeah, they can see
you.
My name is Antonia Chen.
You're
I'm one of the arthroplasty doctors here at the Rothman Institute. And what I'd like to talk to you about is about hip and knee replacements, what you need to know about them. So what is arthritis? First thing is, what are the causes to needing a knee or hip replacement? So osteoarthritis is the most common. That's the wear and tear. There's a bunch of other ones though. Psoriatic arthritis, rheumatoid arthritis, lupus. These are all different inflammatory conditions that can make a difference and cause degeneration to your joint. So what does joint degeneration look like? So look on the right side here. And you can't see from my pointing here, but on the very right side of the knee, on the right side, it's this nice white shiny cartilage. On the next one next to it, you can see it looks degraded, doesn't look happy. And here's an x-ray version of it where it's bone-on-bone contact. So when people talk about bone-on-bone contact, that's what's happening. Your cartilage is degrading, it's gone, and literally your bone's touching bone again. And that's what hurts a lot. Same thing for a hip. On the bottom part of the hip, you have a nice white shiny cartilage surface, and the one next to it is when it's all degraded and done with, essentially. So what is the knee anatomy? So we were just talking about this before, about what happens in the knee or the anatomy. We'll look at the hip in a second, but this is the knee. So the most important thing is think of the thigh bone, which is the femur. The bottom part is the shin bone. So these are called femur and tibia, and this is the part that goes bone on top of each other. Patella is the kneecap, and in it you can see the shiny white cartilage, and you can see the meniscus underneath. So these meniscus here are the area here that kind of carves as a cushion. Well, with time they probably tear, and then the cartilage, this white part here, denigrates, becomes bone-on-bone contact, which becomes a big problem. So how do you treat it? Well, we've talked here just about replacements. You have talked about things like shots before, injections, medications. All these things are very useful. Ice, heat, things like that are very good for treating knee arthritis. But when all those things fail, what do you do with the knee replacement? Now we have a veteran knee replacement patient in the audience who knows what it's like already. But this is what happens. So we start off with dealer's choice of how you do it. So you can do the end of the femur here, and you do the top of the tibia. And by cutting those, you actually replace them with metal. So the bottom part there is the metal replacement that goes on the cap of the femur. So we don't take off all the bone, we literally resurface the bone. And the bottom part too is we resurface the top of the bone, or the top of the shin bone, which is the tibia, and then we put a plastic piece in the part here. Now with the plastic piece, it lets you to glide nicely and bend your knee and move again. And then we actually, almost all of us, most of us here at Rothman Institute, cut off the patella and put on the end. So on the kneecap, we shave off part of it, not the whole thing, and put on a plastic piece. So if you hear some clicking in your knee, that's actually very normal after surgery. That's the plastic piece hitting against the metal. So that actually normally happens because metal and plastic, you put them next to each other, they're going to make a little noise to it. This is what it looks like after surgery. So you have the metal part, and the plastic in between. And then you also have the x-ray version of it here too. So when you look at an x-ray, white is the metal, as you can probably guess, and this is your new resurfaced knee. For hip anatomy, this is what we're talking about in regards to where does it hurt. So when a patient comes in and asks, where does it hurt? What you're looking for is actually the groin. And the groin is this area here. The ball and the socket is actually deep inside. So if you imagine here, this is the middle of the hip, right? The center of it. So just to the sides of it is actually where your hip really is. So groin pain is real. That's where you experience when you have arthritis. So you have here the ball and socket. So this is the ball and this is the socket. And this is the nice cartilage that's normally there, but with arthritis it wears with time and goes away, unfortunately. So what does a total hip replacement do? So I had a patient asking us, do you put it in the bone? Does it fall apart? What happens? So you put the actual part here, and you can see the cup part here, right? So the cup sticks into the bone and actually grows into the bone, which is what you want to see. The next part you have is plastic. So this white part here is plastic, and that locks into the cup. So once that locks in, you're pretty set there, which is good. Now where it's not locked in is the ball. So this part here is the ball, and that ball goes into it, and this attaches to the stem that goes in here. And that's for biomechanical reasons. It keeps it from levering out. So you have titanium. Most of us in this practice do plastic and we do ceramic. And those are normally the bearing surfaces. So if you think of the hip, if you just left this like this, that plastic liner, the ball, would come apart. But that's where all your muscles come into play. And that's why we keep all your muscles intact and sew them back together, because they keep your hip in. That's how you keep walking. So that becomes your new surface. So you take away that bad cartilage, and then you replace it with the plastic part and the ceramic ball, and that moves very nicely. All right, so that's how it works with a total hip. And this is what an x-ray looks like, for a good x-ray after this. So what are the outcomes? So for total knees, these are probably the incisions. You guys can probably demonstrate. The incision straight in the middle of the knee here. And on the hip, most of us do a side approach. Some of us do a front approach. Some do a back approach. Either approach, it doesn't matter. An incision that's appropriately sized, and then we can appropriately get the components in. And ideally, we get you back and up and walking again and back to your activities. That's the goal of doing surgery. So while hip and knee replacement may not be for everyone, at some point in time, if you do have to undergo it, your outcomes are normally very good. Much better with a hip replacement than knee replacement. But overall, you work together with your surgeon, you get normally very good outcomes. That's it. Nice and short to the point. More so because I want to open it up and talk to you guys and ask questions. So I don't know if there's questions from there or not, but I'd like to start with you guys. Do you guys have any questions?
I was wondering how to stay where it's supposed to be.
That's a fair question. So for a knee replacement, we have the beauty of having ligaments, which is very helpful. So this ligament here is called the middle side of the ligament, medial collateral, and this is the lateral, the outside. And those ligaments stay in place as you're doing knee replacement. We don't cut those. So afterwards, you might feel an unnatural feeling because the knee that goes in is not the same as the one that was there before. But most of the soft tissue, such as the ligaments, are still intact. We normally take out the ligaments in the middle here. We take those. So there might be a little bit of rolling with it, but everything stays intact because of that. We also, most of us use cement. Some of us don't use cement, some do use cement. But either way, it interdigitates or basically holds onto the bone. So with the without side. So that's why it doesn't go anywhere. So in the knees, we're more likely to use cement. In the hips, we rarely use cement.
Now in the hip, they wasn't using cement. They were using something natural, or what was that one time? Do you remember that?
So that was way before my time.
Right. Mine was under 94.
So that's when 94 cemented hips, and to this day are actually still the longest surviving hip replacements. The downsides of it are, one, it can interface between the bone. So you have a few interfaces. You have the metal, then you have cement, and then you have bone.
Right.
So it can fail in multiple places. So we prefer to use cementless now.
Okay.
But cement was used for hips for a long time, and it's not used for hips as much anymore.
Okay.
So we've changed.
How about when you gain weight or lose weight? Does that change anything?
So where there is a problem with gaining weight or losing weight's always a good thing. Harder to do, but a good thing. Gaining weight is for every pound you gain 4 to 7 across your joints. So your knee might feel better than it was before, but if you put more pressure on it, it's going to hurt 4 to 7 times more. So that's what makes it hard. So that's where gaining weight is tough. And they've done studies where after surgery, a third gain weight, a third lose weight, and a third don't change at all. So that's okay. But losing weight, or at least maintaining weight, puts less pressure across the knee and the hip. And the benefit is that it causes less wear. So with time, they're like, well, how long does a hip or knee replacement last? It depends on how long it wears. So if you wear for longer, so if you have less weight on it, it'll wear less. If you have more weight on it, it'll wear more. That's where the downside is.
And it also involves how much you inject to your activities to it.
Exactly.
If you're skiing and
if you're doing mogul skiing where you're
mogul
bending up
skiing.
all the time, you're
Uh-huh.
probably going to beat up your joints a lot
Right,
faster, right? But if you're not, if you're just doing
more
activities,
walk
walking,
and just regular things.
it happens less. But I say too, the whole point of getting a hip or knee replacement is to go back to the life that you wanted to have. So if that means going back to the other activities.
And actually, what is the difference that they were saying about the less invasive, like a lot of groups are coming out, oh, we have a less invasive one than the regular one.
Yes, for hips and knees, but mostly knees, what I'm talking about. So there's a phrase out there that talks about the quad. So what's the quad? And they don't actually have it drawn here. The quad tendon is a tendon that goes from the kneecap and goes upwards.
Correct.
And what it does is it basically allows you to straighten your leg or kick your leg out, right? Whenever you do that, you're using your quadriceps. The key is you want to do, there's no such thing as a free lunge. The can't get into your hip or your knee without cutting through something, right? You have to cut through something because you're not hanging out with your knee. So what they talk about are where do you make your cut in that muscle or tendon?
Okay.
So none of us cut across the tendon because then you can't walk afterwards. That would be bad. Either cut along it, to the side of it, or underneath it. Now the benefit of the underneath part is that sometimes they show the recovery is a little faster. But after 6 weeks to 3 months, the recovery is the same. So early recovery makes a difference. Long-term recovery makes no difference. The downside, though, with that type of approach is that they found that the alignment or how they put the parts in can be a little bit off because you can't see as well. So it's a trade-off. You get faster recovery, but your components may not be in the ideal location and vice versa. So I say there's no such thing as a free lunch.
So would that make your feet shorter or something?
It can cause the components, if they were rotated incorrectly, it can affect how long they last. So you may not see it immediately, but down the road you might see it. So that's the top part. But I know great surgeons who do minimally invasive, they call approaches, where they put it in the perfect spot. And that's okay, that's good. And then vice versa. You have people who have way exposed, cut a long time, then don't have it well aligned. So these are all things that are associated with it. I would never choose a person based on how they attack the quad, essentially, or how they make the approach. As long as that person is very comfortable with doing that approach and has done it a lot of times, then it's a good approach. That's what I'm saying. And the same thing for hip too. People come to the front, to the side, to the back. There's downsides to all of them. So in the front, you can have some nerve problems. Down the side, you can have limping afterwards. In the back, you can have dislocation. None of them are perfect. But the goal then is to choose a surgeon that you feel comfortable with, who's done that approach many times, and the patient's happy with the outcomes. So.
What's the problem with doing a hip and a knee?
The hardest part is rehabilitation. That's what it comes down to, is that you literally don't have a good joint to walk on. So normally, people have done it before in the past, but normally we do the hip first because the hip has a faster recovery, and then do the knee afterwards. So you can do both, but most people will do one at a time. So, because the last thing you want to do is, because you can't rehab your knee because your hip is still hurting, then you lose both of them.
So which one, you just had to tell a person which one, like you say, hip first.
Hip first. I would do the hip first. The recovery is faster and patients do well afterwards. And then quickly afterwards, often do the knee.
So would my knee be the same size as his knee?
Well, that's a good question too. So the answer is we individualize every single implant for who the patient is in front of us. So we do this in 2 ways. One, beforehand, we make you all get x-rays here. And the reason we do that is because we have digital templating. So we actually template, we can say, all right, this is the side that fits this or this other one. The second reason is because we're in the operating, there you go, she's got a pretty wound. I love it. we got Vanna White here.
We're going to check that now.
Exactly. You can come up here and give the presentation. We'll be set to go. I love it. So it's different, each person. So he's got a strong leg, right? You were an athlete beforehand, so his bones are probably bigger. With bigger bones, I'll put a bigger component. So when I'm in surgery, I look at it and put the component that I think is right. You might be a little bit different. I've seen women who have big bones. I've seen guys with small bones. So we fit what's right, not by gender, not by ethnicity. We do it straight up because of what your bone looks like and what fits best. So.
And what was happening too with a lot of different operations, when it got to be real problem, everybody started putting the shingle out. They wasn't using the right size for that person. Like my size would be different than your size or whatever. If you don't do the right size, that's when you come to a situation where you can have a bad gait, where your gait be.
It changes.
That changes.
The pain and things like that.
So you gotta go to the best.
Can you make my stitch kind of pretty? Because I wear shorts.
I'm gonna say we do bikini looks with the girls. So keloids are a hard thing, actually. We have patients who get that, and it's very hard to prevent. So what I always tell patients beforehand is, if you have a high rate of scarring, you've got one, and you'll see it forever, because
a lot of people ask me, a lot of doctors ask me the way it's not keloid.
That's
it looks good, and so it depends. If you have a higher risk of keloiding, you're higher likelihood of keloiding after knee and hip surgery. What we do for most of our patients is, when we stitch up the skin, we run suture underneath the skin, so no staples most of the time, and that makes it a little prettier too.
Do you use a cream or something to?
So what we do actually here is after we do the stitching, we put a little glue on it. So the glue kind of keeps the skin together, and that makes it nice. Actually, it makes it a thin incision.
Right.
Most of us use a bandage. It depends on which hospital. Here at Jefferson, we use a silver bandage, and we cover it up, and it heals pretty nicely. After it heals, after 4 weeks, we always say start putting the creams and the lotions and things like that. And patients like using scar cream sometimes, things like that. They're absolutely okay to use after that. But once the incisions heal, not early on. But if your knee feels better, you're not going to be concerned.
I know.
I think. But we're girls, we understand. You guys don't care. It's okay.
All you got to do is put a tattoo over it.
Exactly.
Fake tattoo going down.
No one will know the difference, right?
Nobody will know. There you go. So you got a tat. The kids say you got a tat.
It is.
It's a tat.
So a lot of different options.
Now, getting the knee done in, what was that? This is what, 15, that was 11. Getting the knee done. So now, to do this hip, how would that interplay with that, in a sense? Like now, I have everything on your side, but how does that play in as far as my everything? That is just like, it's just two separate operations, right?
It's two separate operations,
Right,
exactly.
okay, gotcha.
So it doesn't interplay unless you do them at the same time. If you
Okay.
do it separate times, one's already healed and recovered, so it's a different
Right.
separation.
So this is just like getting the hip
It's
replacement.
just like a hip
And it fit right in and that's it.
exactly.
Okay.
The only time it becomes a concern if there was a previously knee procedure and you had multiple knee procedures, or you have a step,
I see.
and then if you put a hip stem on top of it, you don't want them to hit each other.
Okay.
That's the only time you can be concerned. But for a knee for the first time, no problems at all.
What worries me is that the fact that, okay, after I get this hip done, if I do get this hip done, I'm in rehab now trying to strengthen it.
Right.
I don't know if that's gonna work.
You
But
will.
Dr. probably told me I'll see him soon.
You will see him again, that's for sure.
I didn't want to see him. He said, I'll see him soon. But the main thing is that if I got all this and I had this one good knee here, when is that gonna go?
That's the $1 million question.
When is that gonna go?
So the answer is no one knows.
You know, don't
No
know.
one knows. And I'll tell you this, we treat patients. I don't treat an x-ray. If your x-ray is bone-on-bone arthritis, but you feel fine, I wouldn't touch you. I wouldn't do surgery on you. When it hurts, then we do it. So it may stay good for the next 50 years of your life, you know? But
What you found in my experience of talking to people and going through this, everybody's different.
everyone.
What works for you might not work for me,
Exactly.
work for Daryl, 3 different people. That's the way it goes.
Pain controls like
Right.
that, you know, everything like that is a little bit different for everyone. You find what works for you. So you've done it twice now, or multiple
3
times now,
times.
yeah, with the revision.
3 times.
So you know better than most.
Mm.
Which is cool.
That's a good procedure, though. I mean, once you get it done, you're glad you did it. You're glad you did it
The most common question I get asked is, why didn't I do this earlier?
earlier. Yeah.
So why did I wait so long? That's always the most common one.
Yeah, but I had no trouble.
Until now. And if you don't have trouble, why do it, right? That's why I said we treat the patient, not the symptom, not the x-ray, not what someone tells you you should do, but how you feel. When it starts hurting you and affecting your activities.
Now, doctor, also, if you had, like, from being an athlete, and I know my muscles and different things, so if I had always had growing problems, is there any way to rehab to make the groin stronger? And it may not be as much as the hip, or how does that work?
That's a tough one. It depends on why you have growing pain. So
Uh-huh.
there's multiple reasons you can have growing pain. There's muscles and tendons over
Right.
here that causes flexion of the hip or
Right.
moving the hip upwards.
Right?
And one thing it can be
That's
actually
when I have a
hip
problem lifting.
lifting it. That becomes weak every time. It gets painful.
Correct.
If you're like for younger athletes, like their 20s and 30s who have hip problems or groin problems, it's the labor or the other parts of the you can show here,
Uh-huh.
like here. So this kind of here, like this is the labrum. This is the area here that can also be degenerated as well.
Okay.
It can be torn like a meniscus.
Mhm.
So it could be a different cause of it, and that's where the rehab would be different.
Okay.
So, but strengthening this muscle here in the front is hardest to do because of the hip arthritis,
Right.
but that's actually an important muscle.
Okay. Core muscle.
And core heat is here,
Okay.
but it's more of a muscle that helps with gait or walking.
Right.
So if you can strengthen the quadriceps muscle
Mhm.
or the iliopsoas muscle,
Right.
that makes a big difference.
Okay.
Hard to do, but
Mhm.
helps.
So in other words, shooting a chemical residue.
Shots.
It doesn't work. I mean,
So it can work. Again, this is an individualized treatment. It can work on one person and not work on another person. There's two types of main injections we use. One is a cortisone injection. And cortisone is helpful because it's anti-inflammatory. So as you said, if you have arthritis, that's inflammation in your knee, you put the cortisone in, it reduces the inflammation. That's good. The other one's called visco supplementation. It's the gel shot or the chicken comb people talk about, the rooster comb. What it does is it almost acts like a gel or a cushion for the joint. So you put it in, it helps cushion the joint and give you some lubrication to it. So they work in two different ways. And some people, they work great. I've had a patient who did it and lasted a year on it. I had a patient who did it and felt no difference for the gel shot. For the cortisone injections, I've had people last a few hours. I've had some people last years on it. So it really depends. Unfortunately, that's individualized treatment, but it's worth trying. If you haven't tried it before, it's definitely worth trying it the first line.
I had gel shot. It's much better than
Is it?
was.
Good.
Yeah,
Oh,
it
it's
was.
horrible.
But,
Yeah, you're
it's not as bad as it was.
got it. So that helps. So that's good. And if it works, keep doing it. You know, it can't hurt to try. So
But eventually, you're gonna have to get the remission.
it's up to you. The nice thing about it, I know, you're feeling it. You're walking with crutches now. It's tough. The hardest part is this, is that, or the best part is that it's a hip and knee, right? So it affects how you walk and how you live, but it's not your brain, it's not your lungs, it's not, right? It won't stop you from
Your
living,
lifestyle.
but it's your lifestyle. So
Right.
when you want your life back, that's where you do it.
Last year, you know,
What's that? You want to go back to skiing and hunting then? That'll be important. Makes it good. Any more questions, guys? Any questions from the audience?
Nope, they
Okay.
were there and they left us,
Okay.
so.
They were bored of us. We were having a good time. All right, guys. Thanks, I appreciate
Thank you.
it.
Appreciate
If you have
that.
any questions, let me know.
All
right.
Thank you.
Cool. All right. Shut this off or I give it to you? I get some pizza?
Yeah.
You guys want, you don't want pizza at all? Guys?
No, we're good. I'm good.
Oh, you're
I've done it before.
You guys are smart.
Now, if anyone's interested in scheduling an appointment with Dr. Chen while they're here, we could do that for you. If you are going to take it home, digest everything, if you just want to have our number for future reference,
Oh, well, yeah.
take one of these cards here.